Welcome back to the deep dive. Today, we are doing something that I have been wanting to do for a long time.
Oh, yeah.
Yeah. Usually, we take a stack of articles or a new nonfiction bestseller and we break it down. But today we are scrubbing in.
Metaphorically speaking, I hope. I certainly hope you haven't brought a scalpel into the recording booth.
No sharp objects, I promise. But we are tackling a beast of a text today. We are opening up the absolute Bible of general surgery, Baily and Love's Short Practice of Surgery, 28th edition.
Okay, the big one.
The big one. Specifically, we are zooming in on Chapter 76, the Vermiform Appendix.
It really is the gold standard.
Yeah.
I mean, that's the text that has guided generations of surgeons through their residency, through their exams, and focusing on the appendix is, it's a perfect choice.
Why do you say that?
Because in many ways, it is the quintessential surgical topic.
That's what struck me as I was reading this chapter. You think of the appendix and you think basic, entry level.
Right. It's the first major operation a trainee usually does.
Exactly. But the more I read, the more I realized this little organ is a massive paradox. It's simple enough to cut out, but diagnosing it, that seems like it's much more art than it is science.
You just hit the nail on the head. It is an enigmatic challenge. You can have all the CT scans and blood tests in the world, but diagnosing appendicitis often comes down to, clinical intuition, a careful hand, and understanding the subtle signals the body is sending.
The great masquerader.
The great masquerader of the abdomen, absolutely.
And that is our mission today. We are not here to replace the textbook. We aren't going to, read you the pages word for word. We want to be your ready reckoner.
I like that term.
We want to interpret Baily and Love, give you the mental anchors, the metaphors, and the logic, so that when you face a patient clutching their right side, the text just comes alive in your mind.
Think of this conversation as the scaffold. We'll build the structure of understanding, but you still need to go back and read Chapter 76 to, hang the drywall and paint the room.
Right.
You need to see the diagrams and the pathology slides for yourself. But we'll make sure you know what you're looking at when you get there.
Okay, let's kick things off with a bit of a zoological curveball that the book throws right in the introduction. The appendix itself, this worm-like tube, it's actually quite rare in the animal kingdom.
It is. It's a fascinating evolutionary quirk. According to the text, the vermiform appendix appears only in humans, certain anthropoid apes, and the wombat.
The wombat! I love that. I just have this image of a nocturnal burrowing marsupial showing up at the ER with right iliac fossa pain.
Diagnosing a wombat would be a nightmare given their anatomy, I'm sure. But in humans, it's a blind muscular tube. Structurally, it's the undeveloped distal end of the cecum.
The first part of the large intestine.
Exactly. And while we joke about it, knowing the anatomy is literally a matter of life and death.
So let's get into that, the lay of the land. Because if you are a surgeon opening someone up, especially in an emergency, it's not like the clean, color-coded diagrams in the book, is it?
Not at all. It's messy. There's inflammation, loops of bowel everywhere.
So how do you actually find the thing?
That is the first hurdle. The appendix can be incredibly elusive, but Baily and Love gives us a navigational tool that is absolutely fail-safe. We need to talk about the Taenia coli.
The Taenia coli. Okay, so these are the 3 longitudinal ribbons of muscle that run along the outside of the colon, right?
Correct. They look like 3 distinct white bands.
Mm-hmm.
And here is your first major mental anchor for the day. The Taenia coli are your yellow brick road.
Follow the yellow brick road.
Exactly. Even if the abdomen is a hostile environment full of pus or, adhesions from previous surgery, the base of the appendix is constant. It is always found at the confluence where these 3 Taenia coli merge on the cecum. So you find a Taenia, you follow it down, and it will inevitably lead you right to the base of the appendix.
That's really reassuring. The base is fixed. It's your lighthouse. But the tip, the rest of the worm, that's a whole different story.
The tip is a wanderer. The text compares the position of the appendix to the hands of a clock. Imagine the base is the center pivot of the clock face. The tip can point to almost any hour.
And this isn't just, trivia for an exam. The position of the tip dictates where the patient feels pain and what other organs get irritated.
Precisely. Let's break down that clock. By far the most common position, we're talking about 74% of cases, is the retrocecal position.
Behind the cecum.
Right. It's tucked up behind the cecum. It's effectively hiding in the back.
The shy appendix.
Yes. And that shyness makes it dangerous because it's separated from the front abdominal wall by a gas-filled cecum. We'll get to how that confuses the exam later.
Okay.
The next most common is pelvic. That's about 21%, where it just hangs down into the pelvis.
And then you have the real outliers. The book mentions malrotation.
It does.
Yeah.
I mean, during fetal development, the gut rotates and descends into place. If that process stops early, you can end up with a subhepatic appendix, meaning it's way up under the liver, right near the gallbladder.
So it could look like gallbladder pain.
It could absolutely mimic cholecystitis. Or, in very rare cases of total intestinal malrotation, you can have a left-sided appendix.
Imagine the confusion there. You're working up a patient for diverticulitis on the left, and it's actually appendicitis.
It happens. And if you don't know the embryology, you'll be completely lost. But there is one more anatomical feature we have to stress. This is a critical concept for understanding the pathology.
Okay.
We need to look at the blood supply.
The appendicular artery.
Right. It's a branch of the lower division of the ileocolic artery. But the key phrase Baily and Love uses, and this is what you need to underline in your mind, is that it is an end artery.
An end artery. Let's unpack that because it sounds fatalistic.
It is. Think of it like a cul-de-sac or a dead-end street in a suburb. It is the only road in and out. There are no side streets connecting to other neighborhoods.
So no backup plan.
There is no collateral circulation. In other organs, like, say, the stomach or the face, if you block one blood vessel, blood can just detour through another network.
Right. They have redundancies built in.
Exactly. The stomach is incredibly vascular. It's hard to kill stomach tissue just by blocking one vessel. But the appendix, if that one end artery gets blocked, either by a clot or just by external pressure, the blood supply is zero. The neighborhood dies.
And that leads directly to gangrene.
It leads to necrosis and gangrene very, very quickly. This vulnerability in the blood supply is why appendicitis is an emergency. It's not just an infection. It's an ischemic event waiting to happen.
And there's one microscopic detail the text mentions that explains why this hits young people so hard. The lymphoid tissue.
Yes, the submucosa, the layer just under the lining, is packed with lymphoid aggregates. It's basically the same tissue as your tonsils.
Okay.
And just like tonsils get huge in teenagers and young adults, this tissue in the appendix is most prominent in youth.
So you have a narrow, blind tube fed by a single dead-end artery, lined with tissue that likes to swell up at the slightest provocation. It sounds like a design flaw.
It is a perfect setup for a closed-loop obstruction, which brings us neatly to the mechanism of the disease itself.
Let's move to that. We've set the stage with the anatomy. Now let's talk about the main event. Acute appendicitis. The text describes it as a pressure cooker. What kicks this all off?
The fundamental event is obstruction. Something blocks the opening of that blind tube.
The door jams shut. What are the usual suspects for causing the jam?
In young people, it's often that lymphoid hyperplasia we just discussed. A viral infection swells the lymphoid tissue, and the tube chokes itself off. In adults, it's often a phacolith.
A phacolith. I've always found that word disturbingly descriptive. Facies plus lithos for stone.
It is exactly that. It's inspissated. That means dried out fecal material mixed with calcium, salts, and mucus. It forms a hard little rock the size of a pea, and it plugs the appendix like a cork in a bottle.
Okay, so the cork is in, but the appendix is still a living organ.
And that's the problem. The lining in the appendix continues to secrete mucus. It's a mucus factory that doesn't know the exit is closed. So fluid builds up, the volume goes up, and because the walls aren't very stretchy, the pressure inside shoots up.
This is where we need to trace the physiology carefully. The pressure rises. What gives way first?
The veins. Veins have thin walls and really low pressure. So when the pressure inside the appendix rises, it squashes the veins flat. Blood can still pump in through the high-pressure artery, but it can't drain out through the veins.
So it becomes engorged, congested.
It swells, it gets red, it gets angry. This is the catarrhal stage. But the pressure keeps climbing. The bacteria that naturally live there, your E. coli, bacteroids, they start to multiply in this stagnant soup. They invade the wall.
And eventually the pressure gets high enough to beat the arterial pressure.
That is the tipping point. The pressure inside the tube exceeds the systolic blood pressure. The end artery is compressed. The fresh blood stops. Now you have ischemia. The tissue begins to die.
And it falls apart.
The wall breaks down. The bacteria punch through. That is gangrene and perforation.
It's a cascading failure. Obstruction leads to venous stasis, which leads to arterial compromise, which leads to gangrene.
Exactly. And understanding that timeline is crucial because the patient's symptoms mirror that internal destruction perfectly.
Let's talk about those symptoms. Let's create a case study. We'll call him the classic. A 20-year-old male student comes in.
Okay. For the classic, Baily and Love insists we follow Murphy's chronology. John Benjamin Murphy was a legendary surgeon, and he laid down a law about the order of symptoms.
Order matters. So what is the sequence?
Pain first, then vomiting.
Pain first, then vomit. Always.
If your 20-year-old says, I was vomiting all morning and then I got this belly ache, you need to step back. That breaks Murphy's law.
Right.
That sounds much more like gastroenteritis or food poisoning.
Right.
In appendicitis, the pain wakes up the nervous system, and the nausea follows as a reflex to the pain.
Got it. Now, let's look at the pain itself, because it doesn't stay in one place, does it? It goes on a journey.
It does. This is the migration of pain, and it is a beautiful lesson in embryology and neurology.
Let's break it down. Phase 1, the start.
Phase 1 is visceral pain. The appendix is a midgut structure, embryologically. When the midgut is stretched or distended, remember our pressure cooker building up, the nerve fibers signal the brain.
But those nerves are vague.
They're very vague. Visceral nerves aren't good at pinpointing location. They map the pain to the center of the abdomen, right around the umbilicus, the belly button.
So the patient points to their navel and says, it hurts here. It's a dull, cramping, achy feeling.
Exactly. It's colicky. That's the obstruction and distension talking. But give it, 4 to 6 hours, the inflammation has now spread through the wall of the appendix. It is now irritating the parietal peritoneum, the sensitive lining of the abdominal wall.
And that lining has different wiring.
Totally different. It has somatic innervation. These nerves are precise. They know exactly where they are. So the pain shifts. It moves from the vague center to the sharp, specific, right iliac fossa.
Okay, so checking question for you, our listener. If you are taking a history and the patient says, it started around my belly button, but now, 6 hours later, it hurts right here in the lower right when I cough, what physiological event has just occurred?
That is the transition from visceral pain, which is organ distension, to somatic pain, which is peritoneal inflammation. If you hear that story, the alarm bell should be ringing very loud.
And there's one more historical clue the text mentions, the hamburger sign.
Or simply anorexia. Appendicitis almost invariably kills the appetite. If a patient is complaining of pain but says, you know what, I'm starving, can I have a burger? You should really question the diagnosis.
Okay, so the classic has migrating pain, he's nauseous, and he has zero interest in a burger. Now we have to examine him. Part 3. The art of diagnosis. Everyone talks about McBurney's point, but I feel like people just point to random spots on the belly. Baily and Love is very specific.
Precision is key. McBurney didn't just wave his hand. He defined the point very precisely. It lies on a line drawn from the anterior superior iliac spine.
That bony prominence on the front of your hip.
Right. From that bone to the umbilicus.
And where on that line?
Exactly 1.5 to 2 inches from the hip bone along that line. That is the seat of maximum tenderness. It corresponds to the anatomical base of the appendix.
Okay, we find tenderness there, but the text gives us these muscle man signs. Rovsing, psoas, obturator. These always show up on exams, but they also explain the mechanics of the abdomen. Let's walk through them.
Let's start with Rovsing's sign. You push on the left iliac fossa, and the patient cries out in pain on the right iliac fossa.
That feels like a magic trick. You push the left, it hurts the right. Why?
It's just gas mechanics. The metaphor here is squishing a balloon. When you press on the left colon, you are displacing gas backward. It travels across the transverse colon and down into the cacum.
I see.
That sudden puff of gas distends the cacum, and since the inflamed appendix is attached to the cacum, that jiggle hurts.
So Rovsing is about referred pressure. Okay, next up, the psoas sign.
This is specifically for the retrocecal appendix, the one hiding behind the cacum. It is lying directly against the psoas muscle, which is a major hip flexor.
So how do we test that?
You ask the patient to lie on their left side, and you extend their right hip. You pull the leg back. This stretches the psoas muscle. If the inflamed appendix is stuck to that muscle, the stretch causes friction and pain.
So psoas sign positive probably means a retrocecal appendix. Finally, the obturator sign.
This involves flexing the hip and knee, and then internally rotating the hip. This movement engages the obturator internus muscle deep in the pelvis.
And if you have a pelvic appendix?
The pelvic appendix, exactly. If it's hanging down there, this movement will irritate it.
So obturator sign positive points to a pelvic appendix. These signs aren't just names to memorize. They're telling you where the tip is located.
Exactly, but we have to circle back to a danger zone, the silent appendix.
This refers to the retrocecal position again.
Yes. Remember we said 74% are retrocecal. If the appendix is behind the cacum acts like an airbag.
Right.
It shields the anterior abdominal wall from the inflammation.
So when you push on the tummy, it might feel soft, not rigid.
It might feel deceptively soft. You don't get that classic board-like rigidity because the infection is hidden in the back. The tenderness might actually be in the loin or the flank. You have to be very careful not to miss this, or you might dismiss it as a back strain or even a kidney infection.
And what about the pelvic appendix, the one hanging down?
That one is also tricky because it's not touching the front wall either. It's down in the basement, so it irritates the neighbors, the rectum and the bladder.
So the patient presents with diarrhea.
From rectal irritation.
Or urinary frequency.
From bladder irritation.
Which sounds exactly like gastroenteritis or a UTI.
Correct. This is why Baily and Love emphasizes that diarrhea in a patient with abdominal pain does not rule out appendicitis. In the old days, a rectal exam was mandatory to feel the tenderness in the pouch of Douglas.
We don't do that as much now.
Now, we rely more on imaging, but the clinical suspicion must be there.
Speaking of things that look like other things, this brings us to part 4, the great masquerader. The differential diagnosis list for appendicitis is just huge.
It's massive. And to make sense of it, the text breaks it down by patient demographics. The suspects change depending on who is in the bed.
Let's start with children.
In kids, the two big confusorgrams are gastroenteritis and mesenteric adenitis.
Mesenteric adenitis. That sounds fancy. What is it?
It's just inflammation of the lymph nodes in the mesentery of the gut. It usually follows a viral sore throat or a cold. The clinical picture can mimic appendicitis perfectly: pain, tenderness.
Just how do you tell them apart?
Baily and Love gives us a clue. It's the fever.
The fever.
In early appendicitis, the fever is usually low grade, 37.3, maybe 37.5 degrees C. If a child comes in with a blazing fever like 39 degrees C and abdominal pain, you should think mesenteric adenitis first, or even lobar pneumonia.
Pneumonia. How does that cause belly pain?
Yes, pneumonia in the base of the right lung can refer pain to the abdomen. Always listen to the chest in a child with a tummy ache.
That's a great tip. Okay, group 2, women of childbearing age.
This is the minefield. The female pelvis is crowded. You have ovaries, fallopian tubes, the uterus.
So you have Mittelschmerz, which is ovulation pain, PID, pelvic inflammatory disease.
And the one you absolutely cannot miss, the ectopic pregnancy.
A ruptured ectopic can be fatal?
Which is why the rule is absolute. Every woman of childbearing age with abdominal pain gets a pregnancy test. No exceptions.
No matter what they tell you.
No matter what. Baily and Love notes that in ectopic pregnancy, the pain usually starts on the right and stays there, unlike the migrating pain of appendicitis. But you need that test to be sure.
Okay. Group 3, the elderly.
Here, the stakes are different. The immune system is slower, so they might not have a fever or a high white cell count, even if the appendix is gangrenous. But the big mimic here is diverticulitis or even cancer.
Carcinoma of the cecum.
Yes. A tumor in the cecum can actually cause appendicitis by blocking the opening. So in an older patient, even if you treat the appendicitis, you have to follow up to make sure you didn't miss a cancer hiding behind it.
Right. It could be the first sign of something worse.
It can be.
Okay, we have our suspicions. Now we need proof.
Yeah.
Part 5, investigation. The text details the Alvarado score.
The Mantrellis score. It's a mnemonic to quantify the likelihood. A scoring system.
Let's run through MANTRELS quickly, because the weighting of the points really matters.
Right. So M is for migration of pain to the RIF, the right iliac fossa. That's 1 point.
Okay.
A is for anorexia, loss of appetite, 1 point. N is nausea vomiting, 1 point. T is tenderness in the RIF. That's worth 2 points.
Ah, so tenderness gets double white. It's key.
Very key. R is rebound tenderness, 1 point. E is elevated temperature, 1 point. L is leukocytosis, a high white cell count. That's also 2 points.
So the lab data is heavy too.
The objective data is heavy. And finally, S is for a shift to the left of neutrophils, 1 point.
So that's 10 points total. What's the cutoff?
If the score is 7 or higher, it is strongly predictive. You probably need surgery. If it's 5 or 6, you're in a gray zone. You need imaging. Below that, it's unlikely to be appendicitis.
Talking about imaging, we love our scanners. Ultrasound versus CT. What does the 28th edition say?
Ultrasound is the first line for kids and thin adults. The big advantage is it has no radiation, which is huge, but it is very operator dependent. And if there's a lot of bowel gas, you might see nothing at all.
So then you move to CT.
And then you move to CT. It's the heavy hitter. Sensitivity is around 95%. It sees everything, the appendix and abscess, other potential causes, but it involves radiation.
And the text makes a specific point about low-dose CT.
Yes, this is important. For young adults, Baily and Love recommends low-dose CT protocols. We could drop the radiation dose by up to 80% and still get a diagnostic image. It's all about balancing immediate diagnostic accuracy with long-term cancer risk.
That makes sense. Okay, diagnosis is made. It's appendicitis. Part 6. To cut or not to cut?
The age-old question.
There's a lot of chatter these days about treating this with just antibiotics. No surgery. Does the book support that?
It presents the data. Can you treat uncomplicated appendicitis with antibiotics? Yes. The initial success rate is about 85%.
That sounds pretty good.
It is good, but you have to read the fine print. The recurrence rate is significant. About 1/4 to 1/3 of those patients will be back within a year with appendicitis again.
So you're just kicking the can down the road.
For many, yes. It's a valid option for high-risk surgical patients, someone with, say, bad heart disease. But for a healthy 20-year-old, surgery is still the definitive cure.
Now, here's a scenario that really caught my attention, the appendix mass. This is the patient who arrives late, maybe 5 days after the pain started, and they have a hard lump in the right side.
This is a fascinating physiological response. The body has realized there is a leak, and the greater omentum, which surgeons call the policeman of the abdomen, has migrated over and wrapped itself around the inflamed appendix to wall off the infection.
So it's a contained mess. Do we rush them to the operating theater?
No, absolutely not. The text is incredibly firm on this. Do not operate on an appendix mass if you can avoid it.
Why? Usually we want to cut out the infection.
Because the tissues are inflamed and stuck together.
Yeah.
Baily and Love vividly describes operating at this stage as operating in cream cheese.
Ugh. That is a visceral image.
It means the tissues are friable. They just fall apart in your hands. If you try to dissect the mass, you will tear the healthy bowel. You'll create a fecal fistula. It is a disaster.
So we wait.
We wait. This is the Oxner-Sharon regime. You admit the patient, you put them on strict bed rest, IV fluids, IV antibiotics, and this is the old school part, you take a marker pen and draw the outline of the mass on the patient's skin.
To see if it grows.
Exactly. You watch them like a hawk. If a mass shrinks, great. You send them home and bring them back 6 to 8 weeks later for an interval appendicectomy when everything is cooled down.
But there must be stop criteria. When do you bail out and operate?
If the patient becomes toxic. If the pulse rate starts rising, which is a sign of sepsis. If the pain spreads, indicating the abscess has burst its containment. Or if the mass gets bigger beyond your marker line, then you have no choice but to go in, knowing it will be a very difficult operation.
Okay, let's briefly touch on the surgery itself. Incisions.
Most of the world is laparoscopic, or keyhole. Now, it's fantastic because it's both diagnostic and therapeutic. But if you have to do open surgery, you have the classic gridiron incision, the oblique cut.
Right.
But the text also mentions the Lanz incision.
The Cuny line cut.
Yes, it's a transverse incision in a skin crease. It heals beautifully. For a young patient who might be worried about scarring, the Lanz is the cosmetic winner.
We are entering the final segment, and this is perhaps the most dramatic part of the chapter, Part 7. The hidden dangers. Tumors.
Surprise inside. It is rare, but sometimes you take out an appendix and the pathology report comes back with a word you did not expect. Neoplasm.
Let's talk about neuroendocrine tumors, or NETs. They used to be called carcinoids.
Right. These arise from the Kolchitsky cells in the crypts of the appendix. They're often yellow, hard tumors, usually found right at the tip.
And there is a very specific rule of thumb regarding size, isn't there?
Yes. Size dictates the surgery. If the tumor is small, less than 1 centimeter, and it's at the tip, the appendicectomy you just did is enough. Cured.
That's it.
That's it.
But if it's bigger...
If it's larger than 2 centimeters, or if it's involving the base of the appendix, simple removal isn't enough. The risk of spread to the lymph nodes is too high. You have to perform a right hemicolectomy.
That is a massive operation compared to an appendicectomy. You're taking out the cecum, part of the colon, the blood supply.
It is. It's a major cancer operation. But for a tumor larger than 2 centimeters, it's the only way to ensure survival.
And finally, we have to talk about the jelly belly.
Pseudomyxoma peritoni, or PMP. This is one of the most bizarre and, frankly, terrifying conditions in abdominal surgery.
The text describes it as a mucinous tumor that bursts. But instead of pus, the abdomen fills with mucus.
Jelly. Liters and liters of it. The tumor cells seed the entire lining of the abdomen, the peritoneum, and they produce mucin relentlessly. It coats the liver, the spleen, the bowel loops.
And the omental cake, what's that?
That's the classic CT scan finding. The omentum gets so infiltrated with mucin and tumor that it turns into a solid, thickened slab. It looks like a cake sitting on top of the bowel.
The treatment for this sounds like something out of science fiction. The Sugarbaker procedure.
Named after Dr. Paul Sugarbaker. It's an approach that changed a death sentence into a survivable condition. It involves two parts, site reductive surgery, or CRS, plus HIPEC.
Let's break that down. CRS first.
Site reductive surgery is the manual part. The surgeon spends hours, sometimes 10, 12 hours, stripping the peritoneum off the abdominal wall, removing the gallbladder, the omentum, maybe parts of the bowel, to physically remove all visible tumor. It's a massive debulking.
And then, while the patient is still open on the table,
HIPEC. That stands for hyperthermic intraperitoneal chemotherapy. They fill the entire abdominal cavity with chemotherapy fluid that has been heated to 42, 43 degrees C.
why heated?
It sounds crude, but the heat helps the chemo penetrate the tissue and kill the microscopic cancer cells floating in the fluid that the surgeon can't see. They circulate it with a machine for 60 to 90 minutes.
It's often called shake and bake.
That's the slang for it, yes.
And the results?
Surprisingly good. Baily and Love quotes a 5-year survival of up to 87% in experienced centers. For a disseminated cancer, that is miraculous.
That is a heavy note to end the clinical part on. From a simple tummy ache to heated chemo baths.
It shows the full spectrum of this little organ.
So we have covered a massive amount of ground, from the wombat to the yellow brick road to the pressure cooker mechanism, Murphy's chronology, and the Ochsner-Sharon regime.
Let's do a rewind check for the listeners. I want to ask 2 quick questions to see if the concept stuck.
Go for it.
Question 1. If you are examining a patient and you extend their right hip and they scream in pain, that's the psoas sign. Where is the appendix most likely located?
Okay, think about the muscle. The psoas is in the back, so that means the appendix is retrothecal.
Correct. If you didn't get that, rewind to the anatomy section. Question 2. In the Alvarado score, which 2 findings carry double weight, so 2 points each?
I remember this because they are the objective ones, the ones you can measure. Tenderness in the right iliac fossa.
And leukocytosis.
Yeah.
High white cell count. Those are your heavy hitters.
Fantastic. Expert, bring it home for us. What are the key takeaways from Chapter 76?
Okay. 1. Anatomy is the map. Use the tenaculi to find the base. Remember, the position of the tip dictates the symptoms and that the retrocecal appendix can be silent.
Right.
2. Pathology is time-sensitive. Obstruction leads to ischemia. Remember Murphy's Law? Pan first, then vomiting.
Virtual.
3. Respect the mass. If there is a lump, put down the scalpel. The Ochsner-Sharon regime comes first.
Don't operate in cream cheese.
Never. 4. Be paranoid. Always rule out ectopic pregnancy in women and check for high fevers in kids, which might be mesenteric adenitis.
And 5.
5. Tumors. Size matters. Remember the 2-centimeter rule. Greater than 2 centimeter means a hemicolectomy.
And I want to leave the listeners with one final thought, something from the introduction of the chapter. We spent so much time talking about cutting it out, calling it vestigial, a useless evolutionary leftover.
But the text hints that we might be wrong. It mentions the appendix is rich in lymphoid tissue. It's a safe house for good gut bacteria, a biofilm that can repopulate the gut after a bout of diarrhea.
And there's that strange correlation with ulcerative colitis.
Yes, it's fascinating. Removing the appendix actually seems to protect against developing ulcerative colitis later in life. It suggests the appendix plays some complex role in immune regulation that we are only just beginning to understand.
So it's not just a ticking time bomb. It might be a misunderstood guardian?
Perhaps. But when it goes rogue, it still needs to come out.
Amen to that. Listeners, thank you for diving deep with us. Please, open Baily and Love, Chapter 76. Look at the images of the lens incision. Look at the pathology of the carcinoid tumor. It will lock all this knowledge in.
Good luck with your studies, and trust your clinical skills.
See you in the next deep dive.